views and opinions expressed in this program are those of the participants and do not necessarily reflect the views of BronxNet or the program underwriters.
Welcome to Public Health America, a 30-minute program on BronxNet where we talk with national experts to promote health and social justice. I'm your host, Dr. William Latimer. We begin by focusing on a current health topic from the COVID pandemic to cardiovascular disease. Our goal is to provide you with not only the best science, but practical tips to live a healthier life. On Public Health America, we also celebrate what studies have long documented, namely the unparalleled value of a college education by setting the stage to pursue a career of your choice, increase lifetime earnings and opportunity, and champion the ability to engage in civil debate. But for many, finding a path to college is neither clear nor certain. What if you're a high school student with supportive parents but feel daunted by the prospect of being the first in your family to attend college? What if you're a single mother or father and want to attend college but have no childcare? On Public Health America, our expert will also talk about decisions they made and support they received that helped them beat the odds. By sharing one or two life lessons, their stories may provide you with the inspiration and method to realize your dreams. This is Public Health America. Welcome to Public Health America. I'm your host, Dr. William Latimer. I'm here with Dr. Evelyn Taiwo, Assistant Professor of Medicine at Weill, Cornell Medicine, and attending physician at New York Presbyterian-Brooklyn Methodist Hospital. Evelyn, welcome to the program.
Thank you. Thank you for having me.
Yeah, pleasure to have you. So, boy, oh boy, what trying times we live in. Now, I know you're doing some critical work on breast cancer and health disparities related to breast cancer. Tell us a little bit about your work.
So, my work really is just a focus on treating prevention of breast cancer in all people, predominantly women, because breast cancer is a disease of women. But what we know in the breast cancer world is that the incidence of breast cancer is actually higher in white women. However, the morbidity and the mortality associated with the disease is higher in women of color, predominantly Black women. The disparities, the widest between Black women and white women, as well as Hispanic non-white women, or non-Hispanic white women, we call it. So my work is really focused on looking for measures to really narrow the disparities that exist in outcomes of women who've been diagnosed with breast cancer as a way of really working towards health equity. So that's kind of a very short summary of what I do.
We've had a number of guests on the program that have astutely discussed health disparities that are so important to discuss and certainly relevant to the Bronx and NYC generally. Let me ask you this. So breast cancer is more prevalent in white women, but the morbidities are worse in women of color.
That's right.
How do we change that? How do we convince women of color to do the preventative measures that will move the needle? Is that a fair question?
I think it's a fair question, but I think the factors contributing to these disparities are, they vary. There's the aspect of trying to get women of color to get screened. So if there's a breast cancer diagnosis, it's happening at an earlier stage where the chances of cure are higher. But then you have the institutional issues as well. So it's not just patients, but it's the structure that we currently live in. So there are things such as genetics, but we do have, health, social determinants of health. We talk about access to care, health literacy. So those factors are wide. So there are many different aspects of what leads to this disparities. It's not just getting women to get screened. It's more complicated and more complex than that. But that's one thing to focus on as well. It's part of what I do.
Sure. Yeah, so tell us more about your work and the efforts you're leading to reduce those disparities.
So I think the first thing, which was one of the questions you asked, was just even awareness of cancer in the community and the importance of demystifying what it means to have a breast cancer diagnosis, to remove the shame that's sometimes associated with the cancer diagnosis. So a lot of the preventative stuff would be really focusing on screening. I think just educating the public about when a good age is to screen, or if there's a family history of cancer or breast cancer history in the family, the need to maybe start screening earlier, and that identifying or getting a diagnosis of breast cancer from screening mammograms is better than showing up with, later down the line with a higher stage of disease. So I think some of the fear associated with screening is actually ending up with the diagnosis. So we're really doing a lot of work being out in the community, whether it's going to churches or just social events in the community, to really educate patients about what it means to get screened and the benefit of screening, and that a cancer diagnosis is definitely not a death sentence. There are many people who are living and thriving post a diagnosis of cancer and who are thriving with a diagnosis of cancer.
So let's talk about screening. What what age should a woman get screened initially?
That's a great question. And the reason why it's a great question is it's a very confusing question. Depending on where you go, the answer is going to be different. You have the United States Preventative Task Force. That's a little bit more of a conservative task force in terms of what they recommend, which generally is to start screening at age 50. You have the American Cancer Society that recommends screening at an earlier age, which is age 40. So what we've sort of decided when you look at all the different groups that exist is basically a patient should have that conversation with their physician. In general, age 40 is when a woman should start getting screened for cancer. A woman who has a family history or has a predisposition or genetic predisposition to breast cancer should be screened earlier. But the average general population is between the ages of 40 and 50. For me, as a breast cancer physician who is focused on underrepresented groups and women of color, I recommend screening at age 40, because we know that a breast cancer diagnosis tends to be at a younger age in many women of color who also tend to have a more aggressive type of breast cancer. So for the patients that I see in the work that I do, 40 is the age that I recommend, which is also the age the American Cancer Society recommends for screening.
Got it. So age 40, get the screening done. That's
Yes.
the message.
Yes.
So, I'm thinking about the Bronx, I'm thinking about NYC. How do we connect folks that may or may not have the best health care portfolio connected to care? Is that part of your work?
It is part of my work, and there are a lot of people doing the work in the community as well. There are mobile mammogram vans that go to different communities where they just screen the population in general, whoever is, of age who can get screened. They will screen those women, and generally they're free. And if an abnormality is identified, then they plug those women into facilities that are closer to where they are, where those abnormalities can be addressed if a biopsy is needed based on the abnormal finding. But really, for everyone should have a primary care physician. A lot of this preventative things are things that a general practitioner, your GP, your family medicine doctor will sort of identify and then refer the patients to the appropriate specialist. But for those who don't have primary care doctors, I mean, when it comes to breast cancer screening and breast health, going to even like the Planned Parenthood, they'll be able to identify and point you to where you can get screening mammograms for free. And then those mobile sites are also available.
What are the so once the mammogram is done, I guess I have a two-part question. One is, what is the prevalence of breast cancer, and what is the treatment if it is found early and the outcome is likely positive?
Right. So the prevalence of breast cancer, the older a woman is, the higher your risk of developing breast cancer. 1 in 8 women will develop breast cancer. That's sort of the statistics. It's been that way for years, at least since we've been documenting breast cancer. In terms of when a mammogram is done and an abnormality is found, how breast cancer is treated, a lot of it depends on the type of breast cancer. So when we talk about breast cancer, it's not just one disease. There are different types of breast cancers. There are molecular markers we're looking at. There are hormonal receptors that we're looking at on this tumors to really identify what type of breast cancer a patient has. Generally, there will be surgery involved. In some patients, chemotherapy may be part of the treatment, sometimes not. In some patients, monoclonal antibodies, which are more directed therapies, will be part of their treatment plan. Some patients will also need radiation. So the type of treatment, we call it, it's more of a multidisciplinary approach. The type of intervention that's required really depends on the type of breast cancer, the stage of the breast cancer, the type of surgery that is performed, whether it's a lumpectomy where the tumor is taken out and the whole breast is preserved, or a mastectomy where the whole breast has to be taken out, which is never the goal. But all of those really determine the treatment that a patient has. So it's always important to communicate that too. Patients have all these fears about what it means to get treated for breast cancer, and one size doesn't fit all.
Sure. I mean, I will say this. That was a very excellent summary. And there's no question that if it's 1 in 8 women age 50 or older, and we want them to be screened at 40. But I have to say, and forgive me, and feel free to push back. Everything you just said scared me to death. So I'm just wondering that, if I'm a woman and I'm not inclined to go to get this screening, and then I hear this litany of the things that I'm going to go through if I have it. Obviously, I need to go because the outcome, if I have breast cancer, is that I may die.
Mhm.
So obviously the alternative is really bad. How do we, communicate to the populace in a way that makes them realize that, they need to do this? Don't be afraid, and it'll be okay. Is that fair?
Absolutely, because I think the fear really is what prevents a lot of people from showing up and getting the necessary screening or imaging to actually detect abnormalities. We'll have patients who've had a mass that they've been able to palpate for a year or two before they show up. So I think part of the conversation, besides encouraging people to go get screened, is really to reduce the fear that's associated with the diagnosis. What I tell patients is most breast cancers diagnosed early have very good prognosis. A patient who has a stage 1 breast cancer has a 5-year survival of 95% or higher, right? A patient who has a stage 4, which is disease that has spread outside of the breast, has a much lower chance of survival at 5 years. So identifying, diagnosing a breast cancer early, for the most part, really doesn't change a patient's overall survival as long as the right intervention is put in place.
Got it. So we're going to take a quick break. This is such an important segment, and I just want to say it again. Get your mammogram by 40. The end, hard stop. And then work with your primary care physician to figure out what the next steps are. The probability is 7 out of 8 will not be positive, but you need to go and do that screening. We'll take a quick break. When we return, Dr. Taiwo will tell us a little bit about her personal story and how her education helped her to have this great career that she has. This is Public Health America. I'm your host, Dr. William Latimer. We'll be right back. Welcome back to Public Health America. I'm your host, Dr. William Latimer. I'm here with Dr. Evelyn Taiwo, and such a pleasure to talk to you about the amazing work that you're doing. In this segment, we talk a little bit about your history and what enabled you to have this great position where you're doing that work. And I always start with the same question. Where were you born, and what were some of your formative experiences?
So I was born in New Jersey and North Jersey, but I actually grew up in Nigeria. So both my parents are Nigerian. My parents were out here trying to get educated and kind of trying to create a life for themselves. So I was born here, raised for a few years, and then moved to Nigeria. So I actually finished high school there before coming back to the US and for college. And then I've been here since then, from college to medical school and all the training that comes after that.
That's amazing. Let's talk about Nigeria for a while. What was your education like? I ran a program that brought folks from many countries, including Nigeria, to the U.S. for training, and so I got to learn a little bit about those about various cultures. But I'm a novice at best. Tell me about education in Nigeria.
So, I mean, we all know, I mean, it's a developing country. And so the educational system, I guess, when compared to, say, the system here in the US, is not ideal. but there are some great schools and great organizations that are really committed to educating the youth and trying to really elevate and allow them to compete with children all over the world. So I was fortunate enough to be able to go to one of those schools, which was actually a public school. This wasn't a fancy international school that I went to for high school. So I got to really interact with, Nigeria is one country, but there are over 300 different ethnic groups. So you end up in the schools with kids from different parts of the country who speak different languages than you do. The country was colonized by the British, so English is their official language. So we did communicate and kind of engage in school in English, but then you had different languages going on in the school. So it was a really interesting and very diverse, experience that I wouldn't trade it for anything. I'm glad that I had that experience.
Sure. No, that's absolutely wonderful. And I can't even imagine the cognitive benefit of having exposure to multiple languages. I think that would be phenomenal. And you had that organically. So you made your way back to the States.
Yes.
Tell us a little bit about where you went to college and what that experience was like.
So yes, I made it back to the States, had family in Texas, in the North Texas area, Dallas, and ended up going to the University of North Texas, which is a college in Denton, Texas. It's about 30 miles from Dallas. So that was it was a very different, talk about culture shock. Even though I was born and I lived in the US for a bit, I'd been gone for so long. So
Sure.
college was a very different, eye-opening experience for me. But I think my exposure to kids from all over Nigeria also made it easy to not necessarily assimilate, but at least to have that comfort with dealing with children and kids from different parts of the country, different, ethnicities, different countries. It was, we had international children at the school as well. So that was a really life-changing experience for me. Besides getting educated, I think the socialization that occurs when you're in college really allows you to know how to really engage and deal with people from all over, right? You go to school, you go to high school, you have your family, and you have a level of comfort with one particular way of seeing and doing things. And it's wonderful to have that exposure to other ways. I think it makes you a more flexible person, and you're able to really function in whatever environment you're in, because you've had to do that being in college with people from all over the country and the world.
What was your undergraduate major?
So I majored in biology. My minor was in chemistry. Although if I could do it differently, I would. I think I came in knowing that I wanted to go into medicine and just sort of assuming that I had to do the sciences. I do have some, affinity for the social sciences. I love anthropology. I love history. And if I had the knowledge that I have now, I would say as an undergraduate, even if you want to go into medicine, you can major in whatever it is that you love. If you want to major in dance or in literature, history, you could do that and still apply and get into medical school.
Sure. That's such a great message. It was a while back that, Evelyn, that I was talking to the admissions director of Columbia University Medical School that gets, 50,000 applications for 300 spots. And his point was, we don't take just the 4.0s. We take the students that majored in dance, that have some degree of a fuller life and what they can bring to the table as a medical doctor. And I think that's consistent with the message you just gave, which I think is lovely. So you did your undergrad in Texas. That's great. Where did you go from there?
I ended up in Philadelphia at Temple University School of Medicine.
Great school.
Yes, so I went to medical school there. I was there for 4 years, and Philadelphia is such an underrated city. It's a great place to learn history of the country as well and get educated at the same time. So medical school was also a completely different experience, right? College, you're exposed to everything. You get to do history, you get to do whatever it is you want to do. And medical school is really a curriculum that's focused and targeted towards making sure you graduate with the tools and the skills and the knowledge to be a physician. So that was a more intense, but also lovely experience. The first 2 years generally were more classroom based, where you're learning pathophysiology, anatomy, histology, and some of the basics. Then the last 2 years are generally more clinical. You're exposed to patients, which is what we all want to do. You want to kind of get your hands dirty. So that was, wonderful, because it was closer to what you really wanted to do. And then you have students who are more research based, who are in medical school with the goal of also getting a PhD, who want to do more bench research. So the medical school also allows you to be able to do that, to choose your path in a way.
Temple's a phenomenal school, and Philly is a great area. Let me ask you this. We've got a couple minutes left. If you were to define the elements of your undergraduate or medical school experience that helped you succeed and, be the best you could be, what would those elements be?
I think for me, really, it's the exposure to different types of people. I think sometimes we enter this spaces being very intimidated by the people that you're in contact with, particularly if your upbringing is very different from the people you're interacting with at a higher level of education. But I think that exposure to them really allowed you to see that you were really the same intellectually, no one's superior to anyone, and you actually are able to understand and see each other's humanity and see the similarities that exist. And I think that kind of confidence really allows you to be whatever it is you want to be. So for me, that was the biggest thing. I think, like I said, coming from Nigeria to the US, different culture, different understanding of how to function, and then realizing, oh no, we're all really the same. These kids are not smarter than me, they're not better than me. We're all friends, we can function together. I think that was the biggest thing for me. I really do.
Sure. That's great. So the connections you made and the unique expertise that you brought to the table, absolutely wonderful and lovely. I want to thank Dr. Evelyn Taiwo. I want to thank our viewers for tuning in. I'm your host, Dr. William Latimer. This is Public Health America. Take care. See you next time.